just want life to get back to normal.
You have the
You
power
have the power to help COVID-19 go away.
Get vaccinated. Vacúnate. Encourage your family, friends, and neighbors to get vaccinated too. The vaccine is safe and effective. Side effects are rare.
Researchers have spent years developing the science behind it.
The vast majority of COVID-19 patients in our hospitals are unvaccinated.
Getting the vaccine will help prevent you from coming to the ICU.
It may prevent your family member from being placed on a ventilator.
The most powerful tool we have is trust in each other.
No one is safe until everyone is safe.
I got vaccinated for my children. I got vaccinated for my elderly parents.
I got vaccinated for you.
Now it's your turn. Do it for yourself and for all of us.
The time is now.
Get
Get
vaccinated.
I'm Jessica Lemon of AARP Texas. As a sponsor, we hope that you're gaining new insights into family caregiving and that you have the opportunity to connect with other caregivers and experts on aging. Family caregiving is a priority for AARP. It is essential to our work today, but that's not all. AARP is doing amazing things to make life better for the age 50+ populations and the generations to follow. We help improve their financial well-being and their health. We want people to contribute to society and local communities and to fully enjoy life. Some of you may already know that AARP has a strong presence throughout Texas in many communities in this great state, including Austin, the capital city where I live and work. Again, this year, AARP Texas is bringing opportunities to our members and others through virtual events, just like this one that we're participating in today. We hope you have the opportunity to enjoy these free offerings. Not only are there programs to help unpaid family caregivers, but there are presentations to help people avoid being victims of fraud. We host fitness seminars and we work with city leaders towards making this an even more age-friendly community. And know this, volunteers are critical for our mission. There are many opportunities for those who can give a little time to volunteer. You can learn more about these local happenings at aarp.org/tx or find us at the AARP Texas Facebook page. But again, of course, family caregiving is a priority. There are 48 million family caregivers in the US, 3.4 million in Texas alone. They provide help to loved ones, usually a parent, spouse, or sibling. Caregiving can be anything from driving a loved one to a doctor's appointment, making sure bills are paid, cleaning the house, or helping bathe and dress. And many caregivers do fairly complex medical tasks. Caregivers come from every generation, from Gen Z to the silent generation, and every racial and ethnic group. And you know, most of us will either be a caregiver or need care at some point during our lives. AARP recently released new research on how much family caregivers spend out of their own pockets to care for a loved one. We found that almost every caregiver spends money on caregiving, and about 8 in 10 routinely spend their own money on caregiving. The average amount that caregivers spend each year is $7,240. That's more than a fourth of their household income on average. Housing expenses like rent or mortgage payments, assisted living, and home modifications make up more than half of caregiver spending, followed by medical expenses. Caregivers also experience indirect financial setbacks, often postponing their own personal savings for retirement. But I am here to tell you there's action that can help. Congress is considering a bipartisan bill called the Credit for Caring Act, which would create a tax credit of up to $5,000 for working family caregivers. This could help offset some of those major expenses that we know caregivers are facing. AARP, along with 80 other organizations, endorse the Credit for Caring Act. Family caregivers are the backbone of our long-term care system, but they are breaking under the pressure. Creating a tax credit for family caregivers is one way that Congress can help. If you would like to learn more about the Credit for Caring Act, visit aarp.org/caregiving. There, you will also find many resources available for family caregivers just like you. So again, that's aarp.org/caregiving. Thank you for listening. Again, I'm Jessica Lemon with AARP Texas, and thank you for all that you do as family caregivers or to support caregivers.
Thank you so much, Jessica. And thank you for joining us this morning. Good morning, everyone. My name is Rob Fabian. I am the Director of Marketing and Communications for Age of Central Texas. We're a regional nonprofit organization, been around for 35 years this year, serving older adults and family caregivers just like yourselves. And we're very happy to welcome you to our 8th annual Williamson County Caregiver Conference. This year, we're going to be talking about caregiving in the new normal. We know that these last 2 years have been especially difficult for us as caregivers. And so we brought some of the best experts we could find for you to talk about some of the issues that we've been dealing with and maybe dealing with here in the immediate future. And today we've got a great presentation. We're going to talk about all things having to do with dementia. But before we get started, I want to go over just a couple of really simple housekeeping options. Number one, I want to let you know that we are recording this session. So if for any reason you get knocked off or you need to leave early, don't worry. We're going to have this recording available to you so you can go back and watch it later or share it with friends and family. We will send you the link to it along with the links for all of this week's sessions a little bit later on after all of the sessions are done. But we did send you a link to the program for the conference. It came in the email that was sent to you as a reminder. And so we want to make sure that you take a look at that program. Not only does it have great information about all of our speakers and our wonderful sponsors, but we also curated a lot of great caregiver resources for you. So be sure and take a look at that. Then also want to remind you that you have a chat feature here on Zoom. It's right down here at the bottom of your screen. It looks like a thought bubble that you would see in the comic strips. We want you to click on that, and during today's presentation, we want you to ask your questions because that's why we're here today. We're here to provide resources specifically for you. So take advantage of this opportunity to ask your questions. After we have our presentation today, we are going to answer all of your questions. Now, we're going to be very cognizant of your time. We said we would end 11:30, and that's what we're going to do. So if for any reason we run out of time and don't get to everyone's questions, don't worry. We are still going to answer your questions. We will contact you directly with the answers. But take advantage of this opportunity. Ask those questions during the presentation. And then finally, we're going to send you a survey after all of the sessions are done. It'll be an electronic survey, and it'll only take you about 2 minutes to complete. But it's very important for us because it helps us in planning for next year. See, we want to make sure that we are bringing the best experts that we can for you to help with whatever the issues are that you're having as a caregiver. So tell us, what are some of the topics that we need to address in next year's Caregiver Conference? Give us that feedback, and I guarantee you that we read every single one of them that comes back. So be sure and fill out the survey when we send that to you as well. All right. It is my pleasure to introduce Alyssa Aguirre. She is the Assistant Director of Dementia Care Transformation at the University of Texas Dell Medical School in the Department of Neurology. She's also an Assistant Professor of Practice for the UT Steve Hicks School of Social Work. She's been a practicing clinical social worker for 12 years, and she's dedicated her career to implementing evidence-based Alzheimer's interventions, advocating for early diagnosis, and supporting family caregivers just like ourselves. She received her master's in social work from the University of Michigan as a Hartford Fellow. She holds a specialist in aging certificate, and in her current role, she provides counseling at the University of Texas Health Austin Comprehensive Memory Center. That's a big mouthful. And she works on several research studies as well. Alyssa, we are so grateful that you are here with us today to talk about all things dementia. going to talk about what is dementia, what are the different types, and specifically for us as caregivers, when we have a loved one who has been diagnosed, how does that diagnosis happen? And then what do we do with that information? So Alyssa, I'm going to turn it over to you.
Sure. Thank you so much for having me. It's a pleasure to be here and excited to engage with you all this morning. And I do welcome you to please ask questions in the chat throughout my presentation. I will leave plenty of time for questions at the end. So I'll do an overview of some of the information that Rob just went over, and then we'll have some time to really interact and discuss together. And so thank you again so much for having me. So as Rob said, my background is in aging and caregiving and dementia. I've known ever since I was a little girl that I wanted to work with older adults, and that's how I landed in social work and in the counseling field. I've worked at the Alzheimer's Association. I've worked in home health and hospice and palliative care. I've worked in inpatient settings and outpatient settings. Thankfully, I've been in this position now for the last 5 years at Dell Medical School, and I just feel really fortunate to be here and be able to share this information with all of you. So today, this is kind of my agenda. We're going to start with just talking about what is a comprehensive memory center and how is it different than traditional neurology clinics. And then I'm going to go over some of the assessment tools and the diagnostic process when someone is being evaluated for a dementia diagnosis. And then finally, I'm going to go over the most frequently asked questions that I get asked in medical visits and in counseling sessions. And then I can't wait to hear from all of you to hear what your burning questions are as well. So there's a lot of confusion about UT and Dell Medical School and UT Health Austin and how it all fits together. And so as you can see in this picture here on the left, the first arrow is pointing to Dell Seton Medical Center. So that's the Ascension, that's the hospital. If you get sick with a medical emergency and you need to be hospitalized near downtown Austin, that is the hospital that you would go to. And then we also have our outpatient specialty clinics. That's there in the middle, that tall building with the orange arrow. That's UT Health Austin. Some of you maybe have visited us here before. We have 15 clinics, and the Comprehensive Memory Center is one of those clinics. It's a dementia neurology specialty clinic. And then on the far right, we have the Department of Neurology, and that's at UT Dell Medical School. And a lot of the other departments are also in that building there. It's a research building. We have, for example, a Department of Population Health, Department of Health Social Work, and some of the other departments there. So that's just a little bit of groundwork to help us get oriented. So right now I'm sitting in the middle there in the UT Health Austin Outpatient Specialty Clinic. That's where we see patients and families. And so as many of you are well aware, today's kind of patient experience, when someone first starts noticing that they have maybe something wrong with their memory or something wrong with their thinking, or a family member notices, you get bounced around a lot. So you maybe first notice that things maybe are changing, and you make an appointment with your primary care physician. You share your concerns. They may do a brief memory screening there, maybe 5 to 10 minutes, asking you some questions about your memory or your family member. After that, you'll probably get a referral to a neurologist. Sometimes you have to wait 2 months, 3 months, 4 months to get an appointment with a neurologist. You go in for that visit, you may see the neurologist for 20 minutes, 30 minutes. Then if they determine that you have a problem with your memory and thinking, you'll get a referral to a neuropsychologist. It can take another couple of months to get in to see that person. Sometimes that testing can last all day long, 4 to 6 hours. Once that testing is complete, they write their report, which takes about another month. They send it back to the neurologist or their primary care physician. If there's any emotional health needs identified during any of those appointments, you'll probably be referred to a geriatric psychiatrist to talk about your mood, such as depression or anxiety, or how that might be impacting your memory. Those notes then also get sent back to either the neurologist or the primary care physician. Oftentimes, the neurologist will order lab work, a urine culture, a brain image, such as an MRI or a CAT scan. And sometimes if you have a lot of medications, you may also need to see a pharmacist. All of this information is then sent back in the electronic world, back to the neurologist or primary care physician. And when all of that information is back, you'll see that physician again, who will then hopefully go over what the results of all of those different tests were, put all of the pieces of the puzzle together, and tell you what they think is going on. Now, I've worked in this field for over 10 years, and in my experience, that type of care is really disjointed. It's confusing for patients, it's confusing for family members. It's incredibly difficult for healthcare providers to navigate the system as well. Make sure they're getting all those pieces of the puzzle back and then interpreting it on their own and then communicating it back to family. And what often happens is things get lost in translation. Family members fall through the cracks. It takes 18 months to 2 years on average to complete that whole process. And what I hear from family members often is that sometimes there was a diagnosis in a person's medical record and they weren't even told, or they finally do get the diagnosis and it's a diagnose and adios from the neurologist. Here's your diagnosis, you have dementia, come back and I'll see you in a year, with no ongoing support for the family member or information for the patient on what this illness is and what to do next and all those questions that you have. And so at UT Health Austin and Dell Medical School in the Department of Neurology, we were so fortunate to receive a large gift from a funder who said, please think about how dementia care can be provided differently. How can we do this better so it's better coordinated and that we can get to a diagnosis faster? So what we did was we spent a whole year designing the Comprehensive Memory Center. And we took a three-pronged approach. We partnered with AGE of Central Texas to facilitate focus groups back in 2016 and 2017. We met with caregivers and individuals living with early stage Alzheimer's disease. Maybe some of you were even a part of those focus groups. And what we did was we asked, what has been your experience going through the diagnostic process here in Austin or from out of state, wherever you came from? And what was that like for you? And what was done really well? And what could be done differently? We also interviewed healthcare providers from other memory clinics across the United States to ask them, if you could redesign a dementia clinic from scratch, what would you do differently? What's working really well that we should also do here and repeat here at Austin? And then we looked at the literature and the research and asked ourselves, what is the evidence-based practice in dementia care? What is best practice standards and how can we do that here in Austin? So that's what we did. And some of the results of those focus groups with AGE of Central Texas told us a lot of really informative things. The care partners told us that getting a diagnosis was fragmented, it was very delayed, it wasn't timely. They felt like it caused them a lot of anxiety during the whole process and that there wasn't a lot of support for them from a mental health standpoint or counseling offered, very limited education about what they were going to be facing. They felt like there was lack of communication among all these different providers. They're trying to juggle and coordinate. And they were also interested in, what can I do? Now that my family member has a diagnosis of dementia, what can we do? Is there research opportunities available? Are there exercise programs? What can we do to stay as healthy as possible? And from the patient perspective, which was equally as important, they were really concerned about their family members, that the doctors never really asked them about how they were doing, and they were really concerned about being a burden to their family members. They had concerns about their own depression and anxiety, and how do I deal with these things that I'm facing, and that lack of purpose after a diagnosis. And they were really interested in more about faith and spirituality, and how can I get support from other people who are going through what I'm going through. And then finally, they shared about wanting to participate in legacy projects. How can I give back to my community? How can I volunteer? How can I spend more time with my grandkids or my neighbors and really live a life in a meaningful way after getting a diagnosis of dementia? So those were the results of our focus group. And with that, we spent a year, like I said, doing these focus groups and these interviews and designing this clinic, and ultimately created the Comprehensive Memory Center. And this is our mission statement. We've been open now for about 4 years. We provide evaluation and treatment to patients and their family members who are living with conditions that impact memory and behavior and cognitive functions. What our goal is to determine kind of on the one side, what is causing the changes? So getting a diagnosis, an accurate diagnosis in a timely manner, and then also providing support, which is a pillar of our clinic that I think sets us apart from other neurology clinics. So integrating all of those things, we are able to give a diagnosis on average in 62 days. So that's about 2 months to get from that first appointment to what the diagnosis is. We have an interprofessional team that's all housed in one location. So we have here on staff a couple of neurologists, a couple of neuropsychologists, a geriatric psychiatrist. We have medical assistant, nurse practitioners, 3 social workers, a speech language therapist, and we all work together. We're not just located in the same building or in the same clinic. We work shoulder to shoulder. We don't even have offices. We all sit in a big bullpen so that we can talk and communicate to each other and consult about patient care. Once a week, we review every single patient that we've seen that week, and all of us share insight and feedback into what we learned about that patient. And together we come up with the diagnosis and what we think the care plan and recommendation should be. So it's not just one doctor saying, this is what I think is going on. It's about a team of 15 providers, all looking at it from different perspectives, from their own lens and their own training. So that really helps with improving coordination of care. We also partner with agencies like AGE and the Alzheimer's Association and St. David's Driving Program to do warm handoffs to community resources here in Austin. We do have longer appointment times. The first visit is around 1.5 hours to 2 hours. The neuropsychological testing is another 2 hours, which sometimes in other places can take up to 6 hours, but we've really honed in on what the most important information that we need is. And I'll go into more detail about what happens in neuropsychological testing. And then every family member gets an appointment scheduled with our social work counselor like myself, which is a 30-minute visit to learn about how they're doing and how we can help support them. And that's an appointment without the patient present. We recognize that it can be so hard to talk about your loved one, especially when we're asking really sensitive questions sometimes in front of them. And so the visit with the social worker is an opportunity to share about sensitive information you maybe aren't comfortable sharing in front of them, or talk about things that are important to you about your own health and well-being with the social worker. And so we do provide ongoing support services such as counseling services with our social workers, and we provide speech language therapy as well here in our clinic. And it's not so much focused on speech and language as it is helping people focus on learning new techniques and strategies to stay as independent as possible. So that may be learning how to use an Uber app. It may be learning how to use an electronic calendar or a paper calendar. It may be learning about new strategies to communicate with people at a dinner party, so that when you just can't find that word, you have strategies to help you think of that word. We also have on-site diagnostics. We have an MRI here, a CAT scan here right in our building. We have the lab work here, so we can do everything here on site. So you're not jumping around from all of these different places. So with that, we did a visit satisfaction questionnaire with patients and family members to learn about, so what do you think about this new way of doing care, where you come in and there are longer appointment times and it's really in-depth, what could be done differently and what do you like about it? And what we found is that patients and families really love it. I think the biggest feedback is that the transparency and the honesty about sharing, you have a diagnosis of dementia, this is what type it is, this is what stage it's in, and here are our recommendations for next steps. And we're going to help support you on the journey to complete these steps. And so it's very collaborative with the patient and family members. And so people felt like that process was really helpful to them. They also liked the team approach and that they felt like they were a part of the story, that they were an important member of the care team. So next, I'm going to talk about getting a diagnosis and assessment tools. So oftentimes I get asked, well, why should I get a diagnosis? There's are there medications that can help with dementia? What are the reasons why? Isn't memory loss just a normal part of aging? No, memory loss is not a normal part of aging. And there are so many things that we can do. And it is really important to get an accurate diagnosis of what is going on. These are some of the reasons why. Both patients and care partners can participate in research and clinical trials. you're interested in participating in research, we have studies right now for both patients and family members to get involved in. They're not always pharmaceutical studies. Some of them are observational studies that help us understand things like right now, one of the studies that we're doing is an observational study for people who identify as Hispanic, and understanding why people who are Hispanic are 1.5 times more likely to develop dementia than their white counterparts. And so that's one study that we're doing right now. We also have a caregiver support study evaluating an online education program about dementia. Another reason to get a diagnosis is getting on the right medications or getting off medications that aren't right for people who have dementia. Having important family conversations, taking that big trip to Europe you always wanted to take, making the legal and financial plans that everyone should do, like establishing a medical power of attorney or advanced healthcare directive. Knowing that you have a diagnosis of dementia can help you manage your other medical conditions, making sure you're taking your medications at the right time in the day. It also helps give us a sense of peace because we have an explanation for the symptoms that we're noticing in ourselves or our loved one. So what are all these tests about? So on the left, you see a picture of an MRI there. And what are we looking for? We're looking for things to rule out other causes of the memory and cognitive changes that the family or patient is noticing. For example, we might be looking for fluid that's building up on the brain that's caused by a condition called normal pressure hydrocephalus. We're looking for strokes or bleeding, vascular damage that could indicate that someone has a type of dementia called vascular dementia. We're looking to see if there might be a brain tumor where there's a mass pushing on a part of the brain that's causing particular symptoms. We're looking for atrophy, and if there is atrophy, and that basically means shrinkage, where is that shrinkage in the brain happening? Is it happening in the area that controls short-term memory? Is it happening in the frontal lobe that controls decision-making? And so those are some of the things we're looking for. Sometimes we can also see if someone has MS or if they have a movement disorder such as Parkinson's disease. We also do blood work. And what we're looking for in the blood work is to see if people's vitamin levels are in the correct range, like vitamin B12 and vitamin D. We're looking to see if their thyroid is in the right range. Sometimes thyroid symptoms can present as memory loss. So we're wanting to make sure that we're ruling out any other reason that could be causing the changes in memory and thinking. We do a clinical interview, which we gather information such as what languages are spoken in the home, what the highest level of education is that you've received. We're looking history of head trauma and concussions. We're asking about surgical histories. We're asking about employment. We're learning about your family. We're asking questions about substance abuse and medications and what were the first symptoms that you had. And we're also asking questions about what services you're utilizing now. Are people using home health services? Have they attended caregiving classes? All of those things help us understand the whole picture of the family system. And then finally, we do neuropsychological testing. And we're looking, that's an example there of the little maze where you draw a line from a letter to a number. So from 1 to A and 2 to B, and then we time how fast someone can do that. So that's an example of one of the tests that's done in neuropsychological testing. And that really helps us determine what someone's strengths are and what areas they're really struggling with when it comes to short-term memory or language comprehension or executive functioning, such as decision-making. Okay, so we know that from research and from what I hear from patients and family members is that healthcare providers who suspect dementia sometimes don't disclose that diagnosis to the family or even document a formal diagnosis in the medical chart. So a study from 2011 showed that caregivers with experience in the diagnostic process reported that it took more than 2 years from the first time they saw a physician about memory problems for a patient to receive a dementia diagnosis. In 2018, the Alzheimer's Association conducted a survey and found that 90% of Americans would want to know if the cause of their symptoms was Alzheimer's disease. That goes up even higher with those who are 60 and over. 95% of participants say they would want to know if they have a diagnosis of Alzheimer's disease. And so one of the reasons when you ask healthcare providers, well, why don't you share when you find that someone has a diagnosis. And the reason is, one of the reasons is that they worry that they're going to be causing anxiety and depression in patients and family members, since there's not really great medications right now to help treat dementia, and there is no cure. But what the research has shown is that most individuals and their family members seeking a dementia evaluation do not experience adverse psychological reactions after a diagnosis. So what this chart is showing, the kind of yellow-orange line there is people who have a diagnosis of mild dementia. The blue line is people who, after an evaluation, don't have dementia, and maybe it's found that they have low thyroid or that it's something else causing their symptoms. And then the purple line is people who are diagnosed with very mild dementia, mild cognitive impairment. And as you can see there, depression and anxiety actually decreases after someone gets a diagnosis of dementia. And that's the same for their companions, their family members. Anxiety and depression actually goes down after they receive feedback about what's going on. Okay. So this is a screening tool called the MOCA, not like the coffee, the MOCA, it's MOCA, the Montreal Cognitive Assessment. Many of you have probably seen this in primary care physician's office or in a neurology office. And this screening tool takes about 5 to 10 minutes to complete. It's very sensitive. It is 90% effective in detecting mild cognitive impairment compared to the mini mental status exam, which is another similar exam. And so you can see that this is looking at different parts of cognition, such as visual spatial recognition and being able to name animals, remembering 5 different words. It looks at attention and language comprehension. It's out of 30 points, and this is often used in a primary care physician office as a screening tool to determine if someone needs a referral to see a neurologist. Okay, so this brings us to the third part of my presentation. I'm going to go over the frequently asked questions that I get in the medical office and from my counseling patients. And then I would love to hear from all of you about what some of your questions are. So one of the most common questions I get asked is, what will the doctor do when I see him or her? We went over this a little bit. You'll answer questions about health history and family history and medications, and we'll ask questions about your mood, probably get a picture of your brain and do some blood tests and other lab work. Patients often say, my family thinks I have a problem with my memory, but I don't have a problem. Everything is fine. Everyone is a little bit forgetful sometimes. And people are right that a lot of people may experience some memory changes as they get older, and it varies from person to person. But we all want to stay as healthy as possible. We all want to maintain our independence for as long as possible. So my response to that is that having a brain checkup is a part of staying healthy. Just like we go when we get our vitals checked, we get our blood pressure and our cholesterol and all of that, and check our sugars to screen for diabetes. Having a brain checkup is just as important as staying healthy. And what might be a good way to show your family members that maybe there's nothing wrong with you and just put it to rest. And so sometimes we discover a reversible problem. In our clinic, there is a certain percentage of patients who come in thinking maybe it's dementia or Alzheimer's disease, and we come to find out that it's a vitamin deficiency, or in fact, there's nothing wrong with their thinking and memory. Sometimes it's untreated depression, and once someone gets on mood stabilizing medications, their memory actually improves. Sometimes it's a polypharmacy where people are on too many medications and it's causing confusion. And so all of those are good reasons for getting a diagnosis. By far, the most common question that I get asked is, well, what is dementia? What is the difference between dementia and Alzheimer's disease? So dementia is an umbrella term. That means that someone is having cognitive impairment. There are different diseases that cause dementia. So it's similar to if someone were to say, well, I've been diagnosed with cancer. You'd say, well, what type of cancer do you have? Where in your body is the cancer? Same with dementia. If someone says, I've been diagnosed with dementia, you might ask the follow-up question, what type of dementia do you have? Where in your brain is it? And so this is a picture that kind of represents the value of real estate and how it's really linked to its location. And the same holds true with brain real estate. Different parts of the brain control different functions. The same lesion in one part of the brain will cause one set of symptoms, and in another part of the brain will cause a different set of symptoms. And so what we're trying to figure out with the neuropsychological testing and the brain scan is to find out where in the brain is causing the problem. And that can help us determine what type of dementia someone has. Alzheimer's disease is by far the most common type of dementia. About 70 to 80% of people have the Alzheimer's type. Other common forms of dementia that we see in our clinic are vascular dementia, Parkinson's disease, which can cause dementia, Lewy body dementia, frontal temporal lobe dementia. They all have different risk factors. They all have varied treatment strategies, which is an entirely different presentation to really go into all the nitty-gritty details of the different types of dementia and what the symptoms are and the risk factors. We'll talk about that a little bit today. But that just kind of helps you understand what is dementia and what are the different types of dementia. So I also get asked about genetics. So let's talk about that a little bit. Scientists so far have identified several risk genes that are implicated in Alzheimer's disease in particular. The gene with the strongest influence is called ApoE4. Scientists estimate that genetics are a factor in about 40 to 60% of cases. If you have a parent or a sibling with the disease, it does increase your risk. And it is not typically deterministic, meaning if you have a parent or a sibling with the disease, it does not mean that you will get Alzheimer's disease with 100% certainty. Everyone inherits a copy of some form of ApoE from each parent, ApoE 2, 3, or 4. Those who inherit ApoE4 from both parents have a more increased risk of Alzheimer's disease. Scientists are really unsure at this point how exactly it increases our risk. Deterministic genes are genes that directly cause a disease. So you may be familiar with something like Huntington's disease, for example, which guarantees that someone who inherits a particular gene will go on to develop the disorder. With Alzheimer's disease, a genetic mutation that's deterministic in this way appears in less than 1% of cases. So when people say, well, Alzheimer's disease runs in my family, what they usually mean is that they have risk genes, meaning that there are people in their family who have ApoE4 and that it increases their risk of developing Alzheimer's disease. With deterministic genes, the familial Alzheimer's disease is caused by 3 proteins: amyloid precursor protein, APP, presenilin 1, and presenilin 2. In these families, symptoms nearly always develop before age 60, often in people's 30s and 40s. There's a few families worldwide that scientists and researchers are working with right now to really understand those families where they have the deterministic genes, one of those 3 genes. We now know that women have an increased risk of Alzheimer's disease. It's the only neurodegenerative condition that affects women more than men. Oftentimes women with the disease in the early stages can go undiagnosed because women tend to do better on the verbal test than men, which can sometimes mask Alzheimer's on a brief screening tool. Some previous studies suggest that women at any age are more likely than men to develop Alzheimer's. We're really starting to look at sex-related differences in hormones, immune function, and energy metabolism that can kind of help account for some of those gaps. There was a study published in Neurology, and it found that women in midlife had a 30% more Alzheimer's-related plaques than men of the same age. So when we're talking about risk, we're talking about changes in the brain that happen in the middle of your life and not just in later life. Okay, I also get asked questions about what can I do if I do have a parent or an aunt or uncle or a grandparent or a sibling who has Alzheimer's or another type of dementia? Are there things that I can do to help protect my brain? And the answer is yes. Research has shown a number of different things that can help decrease your risk for developing dementia later on in life. And there are things that we know increase our risk for developing dementia later on in life. Chronic concussions and traumatic brain injuries do increase our risk for cognitive decline. Midlife obesity, hypertension, smoking, diabetes, all of the things that we think about as heart health are also directly tied to brain health. We know that a history of depression and a history of sleep disturbances also put you at moderate risk for developing dementia later in life. Things that we know can help decrease your risk: having more years of formal education. People with higher education levels are less likely to develop dementia as they get older. And the reason for that, at least the hypothesis for that now, is that people have what we call cognitive reserve. The more education you have, the more kind of robust your nerves are in your brain, and that when people start experiencing atrophy and shrinkage of the brain, that it takes longer to develop symptoms because you kind of built up your brain muscle. We know that physical activity and physical exercise is good for brain health. There's been a lot of research in the last 5 years or so about certain types of diets, such as the Mediterranean diet, and kind of variations of the Mediterranean diet, which is high in omega-3s and nuts and fruits and vegetables and whole grain. Cognitive training, like speech and language therapy, cognitive communication training, we know can help reduce our risk for developing dementia later on in life. And alcohol consumption also can increase your risk. And so moderating your alcohol consumption can help decrease your risk. And there's also some unclear evidence about social engagement and reducing loneliness and being connected to your neighbors and friends and community, that can be a protective factor. This is a graph from the Cleveland Clinic called the 6 Pillars of Brain Health. And it basically just kind of talks about the different areas of the brain and the things that we can do to help be protective factors. So these are some of the things we just went over in the previous slide: physical exercise, getting good food and nutrition, managing your other medical conditions. One of the most common reasons that people with dementia are hospitalized is not managing their other chronic conditions or getting medications mixed up. And so managing all of your other medical conditions is really critical to stay healthy. Getting good sleep and taking care of your emotional health and mental fitness, and then engaging socially with other people. Those are the 6 things that research has consistently showed can help improve our brain health. So thinking about caregiver, or sometimes I will call them care partner statistics, 60% of dementia care partners experience moderate to severe stress. I'm not going to go over all of these things because I understand that you had a wonderful presentation yesterday that really delved into cumulative stress and how that can impact caregivers. So I think that the takeaway from this slide is that for these reasons, they're often the reason that people seek counseling services, either at the Comprehensive Memory Center or other places in the community. Okay, this is another question I get asked a lot. Is my family member in denial? Patients getting diagnosed with dementia have a range of reactions to that diagnosis. In some people, they accept the diagnosis and they're able to recall that they got diagnosed, and a week later or months later are able to have a conversation about that. And we call that insight, that people have insight into their cognitive deficits and with the diagnosis that they have. Other times, people will reject that they have the diagnosis. They're, I guess you could say, in denial, where they aren't wanting to face the reality that there's changes going on. Most often, though, people have what we call anosognosia, which means that they forget how forgetful they are. It's not that they are forgetting on purpose or that they're in denial, but the brain changes that are happening are preventing them from fully understanding and appreciating the depth of their cognitive deficits. And so I think once that we have a better understanding of that, and that they're not doing it on purpose, it's not that they're in denial, it's that the brain changes that are happening are actually causing them to not remember that they have dementia. That is really a first step to kind of moving on towards handling some of the complicated emotions that come from that caregivers, because it can be very frustrating when you're living with someone who doesn't believe that they have dementia or doesn't understand that they have dementia. Okay, so what exactly happens in psychotherapy? We talk about a lot of different things in counseling, and it can really be varied. I see grandchildren sometimes who are caring for a grandparent with Alzheimer's or another type of dementia. I see spouses. I see significant others, partners, adult children. In some circumstances, I have worked, some of our patients have young onset, which means that they are diagnosed with dementia before the age of 65. Sometimes I work with their parents because their parents are providing some of the caregiving because their spouse is still working and providing for the family. And so I work with a variety of family members. What things do we cover in counseling? We talk about sometimes there's a lot of trauma around getting a diagnosis, and people just want to share their story about how difficult it was to get diagnosed and how frustrating that was, or maybe they got misdiagnosed and went on a whole different path before finding out what type of dementia that they had. We talk about how do I tell friends and family about the diagnosis. As I've worked with people in writing a letter or an email, or how to share that with certain people that they are really struggling with how to share this news with. We work on accepting the diagnosis, either with the patient themselves or with the family members. We go over legal and financial planning and the documents that we all should have in place. We talk a lot about communication and how communication changes when you are living with someone who has dementia, and what are the strategies that can be helpful to reduce disruptions and difficult behaviors. We talk about driving and driving retirement and safe driving, which I learned, have a whole session about tomorrow. Talk about spirituality and faith and hope, and how do you go on after you or a loved one gets a diagnosis of dementia. We talk about importance of routine and structure and how to kind of plan your day. We talk about long-term housing planning and what are the ways that people pay for long-term care? What are the different types of housing options out there? We talk about long-distance caregiving and family dynamics when there's challenges with adult children maybe who don't agree, or maybe there's not a caregiver involved. We talk about grief and loss, talk about intimacy, managing behaviors, and caregiver identity, wearing two hats. How can I be both wife and caregiver? And how do I manage the tension between those two things when I'm feeling like I'm a parent? We talk about accepting help and what are our feelings around accepting help? And are we accepting of other people offering to help? And how do I kind of get over that barrier of not wanting to be burdened to other people? We talk about resources that are available in the community. We talk a lot about education with whatever certain type of dementia someone has and what to expect for the future and what stage they're in and how to plan, and then addressing depression, anxiety, and burden. We talk, when we do those things, I provide cognitive behavioral therapy, which is a specific type of therapy that looks at what are the thoughts that are happening in my mind? How is that impacting the feelings that I'm experiencing? And how does that impact the actions that I then have? So oftentimes people will come to me in counseling and they feel ashamed of how frustrated they get, how angry they get with their loved one when they lose their patience, when they kind of snap at them because their loved one has asked the same question 50 times already this morning, and finally they just can't handle it and they snap and yell, and then they feel so guilty about it afterwards. And so we process through what is that like, and what were the thoughts kind of running through your mind, and how did that impact how you felt, and then how do we get to that action where we kind of lash out, and how do I handle my own guilt and shame around what's happening in the home, and how do I handle it maybe a different way next time. I use problem solving therapy. I use solution focused therapy, so focusing on the here and now and the problems that people are experiencing and how we can come up with solutions together based on your past experiences and how you've handled stress and difficult challenges at other times in your life. We do a lot of reminiscence therapy and life review when I'm working with the patient who's experiencing memory loss. And then we talk a lot about grief and loss and values and faith and spirituality. I get asked, is counseling covered by insurance? For Medicare and other major providers, if you have mental health coverage, yes, usually counseling is covered. I can bill it one of two ways. One is that I can bill the patient's insurance, even if they're not present. Medicare has a billing code for that, where I can do psychotherapy with a family member without the patient present. Oftentimes caregivers will just go through their own insurance if they have Medicare or Blue Cross or whatever. And I can just bill like you would if you were seeing a counselor in the community. It just happens to be focused on the caregiving role in depression and anxiety. Oftentimes in counseling, people will present because there's a specific problem going on. And these are some of the questions that I'll ask to kind of get kind of drill down to really problem solve with the caregiver on how we can figure out when is it happening? Is there a specific time of day? Is it happening in a specific room? Is the person hungry or tired? Just thinking about who was the person. For example, I had someone who was a kindergarten teacher, and right around 2-3 o'clock every afternoon, she would get really, really restless, and her spouse just couldn't understand why that 2 to 3 o'clock time frame was just the hardest time of day, and why was she so anxious. And we discovered it was because that was when school would end, and that's when she would be trying to get all the kids home safely to their families. And she would be standing at the window and watching all the kids walking down the sidewalk and be very worried about them and were they getting home safely. And so what they would do, what they decided, is that he would take her for a drive at 2 o'clock every afternoon and drive around and go get coffee or ice cream. And that was a solution that really worked to help reduce her anxiety. And so it's very tailored in that way to understand who is the person and what have been their life experiences and how can we problem solve together. I often get asked about communication strategies. This is really in basically every counseling session that I have when I work with caregivers. This is something we talk about a lot. It is really hard when it's your own family member. I think, I've been a caregiver myself. My mother-in-law lived with MS for many years. I moved to Texas from the Midwest to help care for her. And so I can speak from my own personal experience. I know that it's easy to have all the head knowledge and read all the books and the websites, and the healthcare providers can tell you, well, you should really do this. It's easy, just do this instead. But when it's your family member and they've asked you the same question 100 times, or it's just taking a really long time to get out of the house for that doctor's appointment, it is really easy to lose your cool and get impatient. And so we can kind of talk through that. And one of the things I always emphasize is that it is like learning a new language. There are certain communication strategies that can be very helpful, that are more effective than, for example, reality-oriented approach, which would be something like, if I'll do a little role play here. So, okay, honey, it's time for our doctor's appointment. It's at 10 o'clock, so we've got to leave the house. And the response might be, well, what doctor's appointment? You didn't tell me we had a doctor's appointment. Why don't you ever tell me? You need to tell me about these things. And then you say back, well, I've told you 100 times already today. I told you yesterday. Remember, it's written right here on the calendar. That never gets you very far. And so that's taking a reality-oriented approach where we're using logic and reasoning. And that is how we typically communicate with adults, is using logic and reasoning and reality-oriented. But that doesn't work when you have someone who is dealing with dementia. And so we take a validation-oriented approach where you're affirming their feelings and showing empathy, even though it's really difficult in the moment. You join with them in their reality, which is that they were never told about this doctor's appointment. And then you distract them. So for example, in this role play, honey, okay, it's time to go. It's 9 o'clock. We have this doctor's appointment. What doctor's appointment? You never told me we had a doctor's appointment this morning. Oh, you're right. I'm so sorry. You're right. I should have told you. Next time, I'll make sure it's written on the calendar, and I'll make sure to tell you ahead of time, and we'll make that decision together. But for right now, we just got to get on our shoes. Okay, so kind of taking the blame. We're empathizing with them that it wouldn't feel good if we didn't know about a doctor's appointment. And then we're distracting them to the task at hand. Okay. Grief and loss. A lot of times caregivers are in my office and they're struggling, but they can't quite put their finger on why they're struggling. They don't feel good. They may feel, sometimes people feel depressed, or sometimes they just feel really sad and down. They can't quite put their finger on why. And that's usually a good indicator to me that they're dealing with grief and loss, even though your loved one is still living. And I think that's where ambiguous loss comes in. People are still physically present, but emotionally, cognitively, they've changed. They're not the same spouse and partner that we lived with for so many years, where we can't share the same things with them that we could before. And there's a lot of loss and grief around that. There's a loss of this anticipatory, this future that we imagined when we would dream when we were young about all the places we would go and what we would do when we retired and how our life would be. And when that reality isn't the reality that we're facing now, there's grief and sadness with that. And so processing through that is a part of what we do in therapy. I often get asked what's a good book recommendation. There are some books that are good reference books, like, for example, The 36-Hour Day. Most physicians will recommend that book. If you ask them, what is a good book I should read, they'll say The 36-Hour Day. That is like a good reference book. Do not read that book cover to cover. I have people coming in my office just in tears because of how difficult it was to get through that book and all the things that brought up for them. And so that's a good book if you need, like, I have a question about shadowing behaviors. I have a question about what late stage is going to look like as a reference. I'll give you a whole list of other books that I would recommend you read cover to cover that are really wonderful. One that I really love is this one pictured here by Pauline Boss, called Loving Someone Who Has Dementia. It is focused on the ambiguous loss and anticipatory grief and kind of the communication strategies. I'm happy to recommend other books as well. So with that, I'll just say hook 'em horns, and I look forward to the next 15-30 minutes of our conversation. Please feel free to ask questions in the chat feature. I believe that only me and the other two panelists can see those questions, and so there's no need to be worried about your peers that you may be in support group with, or know from other programs, or neighbors of yours thinking a certain way about a question that you might ask. So nothing is too silly.
That is right. Thank you for pointing that out. Yes, this is your opportunity. Ask those questions of the expert that we have here to talk about dementia. We do have some questions to get us started here. Before we do, though, I wanted to point out one of the things, Alyssa, that you were talking about was affirming a person's feelings and their reality. For those of you who joined us for our Striking a Balance Caregiver Conference last month, you might remember the presentation that Sarah Hyde-Williams did talking about dementia and how to communicate with your loved one who has dementia. And she went through a whole list of I'm sorries and how to use those. And you're not, in many cases, apologizing. You're using that as a tool and offering the apology to the person who doesn't have the capacity to remember that you had told them things. And so you're telling them, I'm sorry that you don't remember. And you're not saying those exact words, but that's what's in your head, is that you're telling yourself, I'm sorry that you can't remember this. But for them, you're telling them, I'm sorry I didn't tell you, because in their reality, they just don't remember. We've got a couple of questions about the gene for Alzheimer's. You know, we hear a lot of people talking about worried that because family members had Alzheimer's or had dementia, do I need to get the testing myself? And in particular, there was one person whose dad did have the diagnosis of Alzheimer's and mother is living with dementia, wondering if they should be checked for that particular gene.
Mm-hmm. You know, we do get that question a lot about genetic testing, either with patients of ours or family members. And I think that's a really individual decision. I think that you ask 10 people, would they want to know what their genetic risk factors are? You're going to get different answers to that question, because I think it's a really personal decision. A lot of our patients in our clinic have done the 23andMe. And I think that does test for the ApoE 2, 3, and 4 alleles. And so that's one option if you are interested in getting kind of a generic genetic testing that can help identify your risk factors for a number of different diseases. That's one that you can do. I always recommend, as best practice, meeting with a genetics counselor, because they can really help you think through what are the benefits of learning about what my risk factors are, what my genes are, and what are things that I should be considering, and how will that change my life if I do find out that I have a condition that's going to impact me for the rest of my life. And I think the ethical question is, okay, well, what if I find out that I am a carrier of ApoE4? That doesn't mean that you'll go on to develop Alzheimer's for certainty. There are people who carry both alleles of ApoE4 from both parents and never go on to develop dementia. And so there's still a lot we have to learn about genetics. And I think especially with Alzheimer's disease, that's something to really keep in mind, is that there's a lot we don't know. And so I guess I'll leave it up to you guys, but that's what I would say if a patient were asking me that in the clinic.
That's a very good point, because that was going to be my follow-up question was, what if you do find out that you have this, carry this genetic marker? And so, yes, being prepared for what, sometimes the answer is yes, sometimes the answer is no. And so be prepared in either case. Got a question from a person who is a solo ager. And we know that here in Central Texas, we have a larger than normal population of folks who are solo aging. A lot of people moved here in the 80s and 90s for their jobs because this was the hot place to come. The kids have graduated, they're gone. Perhaps my spouse or partner has passed away, and now I'm here by myself, and all of my support is back in California or Michigan or wherever I moved from. And so I'm aging here by myself. How do you start preparing for that? And especially in the event of what happens if I do get a dementia diagnosis and I am living by myself?
Yeah, that's a really good question. One place that comes to mind is Capital City Village. Is a wonderful nonprofit here in Austin that works with older adults, and it's a co-op kind of model. And so they have, if you become a part of this co-op, it's like a family. It's a psychological family, and people who can help you do things like get your groceries, or come over and run an errand with you, or just check on you and just friends. And so it's people you can lean on for support, professionals and other people who are part of the co-op, kind of a peer support model. And so I would always recommend getting involved with something like that, or getting integrated into your community. Get to know your neighbors. Not all family is blood. My husband and I live here with 3 kids under 5, and we don't have any support family here. And so you learn that your friends can become your family, your neighbors, your community. So get involved in communities like AGE, get involved in the Alzheimer's Association. Your medical providers can also be a huge support system for you. And so I think solo agers do have to be a little bit more organized sometimes, because they're the ones that are advocating for themselves if they don't have a family member or identified person advocating for them. And it becomes even more important to have a medical power of attorney, to have an advanced healthcare directive, where you're naming who is going to be that decision maker if the event in the event you're not able to speak for yourself. Who is going to make those medical decisions for you that are really consistent with your own values and your own wishes for your healthcare? And so thinking about, whether it's dementia or another condition, do you want to age in your home, or are you open to receiving services in residential care, more like a group home setting, or do you like the continuing care retirement communities where they have all the services there under one roof? And so starting to think about those things and planning for your future and communicating that to people, whether they live far away or your folks here who are in your support network, so that your wishes are really honored and that other people aren't making decisions for you, but it's really how you want to age and how you see the rest of your life, and that can really be respected.
That is such fantastic advice. Yeah, Capital City Village is located here their offices are here at our Age of Central Texas Age building. And so we can help you make that connection. We also can help with being prepared with all of those documents that you need to have as you're aging, that everyone needs to have, not just folks who are aging. Everyone needs to have these documents moving forward. So we can help you with all of that as well. Got a question about a loved one who clearly has cognitive decline. They're living in assisted living, but they are already 90 years old at this point. Is it worth it to go through the comprehensive diagnostic process that late in life?
That is a very good question. And the answer is sometimes. It really, again, is an individual decision. One of the questions that I would ask is it going to change the course of treatment? Are there medications that could help slow down the progression if there is cognitive decline? Maybe. Are those indicated in someone who's 90 or older, has other chronic conditions? You really have to weigh the pros and cons. Are they going to get involved in a research study? Is the family member going to participate in a support group versus not participating, whether or not they know there's a diagnosis? And so I would think about kind of all of those things. For some people, families will just say, it's not as important to us to know the exact stage or the exact type of dementia that they have because we already have the support services in place. They're already living in assisted living. We kind of have what we need kind of set up in place already. And so it's really an individual decision that sometimes, the family will make together. But I would say it's the most important in people who are in the earlier stages. And so for what that's worth, it is harder to determine what type of dementia someone has the further along they are. And so when you get someone who's more moderate to severe, it's harder on neuropsychological testing to really determine what the cause is. And so that's why I say it's a little bit easier earlier on to determine what type someone has.
Right. Following up on that, another person said that their grandfather was diagnosed with Alzheimer's, and the time the family was told that his life expectancy was around 10 years, yet he lived to be 25 years past the diagnosis. Is that common that sometimes we'll be given a diagnosis and a timeline, and the timeline is not correct, and then the family who had planned for 10 years worth of care and financing, now suddenly it's twice or three times as long?
That is really tricky. And it's accurate that on average, people live 8 to 10 years after a diagnosis. But, being in this field for 10 years, I do think that's skewed. And I don't know if that is the most accurate thing, because for the reason is that most people, especially 5-10 years ago, were diagnosed in the middle and late stages for the most part. And so their life expectancy was shorter. I have these timed lights on in here, sorry. And their life expectancy was shorter. And so their average life expectancy is 8 to 10 years. Nowadays, we're diagnosing people with mild cognitive impairment, with very early mild Alzheimer's disease, because our testing is getting better. Those people are living much longer, 10, 20 years with Alzheimer's disease. And so while we're diagnosing people earlier and younger people are living longer, we're also managing other chronic conditions much better than we were 10 years ago. We have treatments for cancer, treatments for heart disease, we're identifying diabetes earlier. For all those reasons, people are just living longer with their chronic conditions. And so those are the things I would think about. How old is someone already, and what are their other chronic conditions? But I think there are people who get a diagnosis, they go in hospice, and hospice puts the diagnosis in their medical record that they have dementia, and then they die a year later. And it does kind of skew the life expectancy a little bit.
Right. And actually, speaking of chronic conditions, we have a question about that a caregiver has a loved one who has dementia, has developed dementia, but also has cancer. And so managing two conditions simultaneously, can you talk a little bit about some best practices for that?
I think one of the most challenging things, especially with cancer, is that there's so many medical appointments and so many medications. And so oftentimes just getting a good system down for medication management, whether that's electronic or a pill dispenser or a paper chart, just the family understanding, the patient understanding, what their medication regimen is, and then also coordinating all those appointments can be so challenging, and rides to those appointments and who the appointments are with. A lot of our patients who have multiple medical conditions will hire a geriatric care management company. And especially for people who are adult children who are still employed full time and caring for an aging family member, that can be really helpful, because the care manager will pick the patient up for their appointment, bring them, take notes during the appointment, coordinate care with the physician, and then, coordinate back with the family and have a summary of the whole visit. And so that can be really nice to have one person that's kind of coordinating all of the different moving pieces. And so for families who are really struggling to manage all of those things, a care management agency can be really helpful. And there's a couple of really good ones in Austin.
That's a great piece of advice. I loved your explanation about why it's so important if we suspect that ourselves or a loved one might be having a cognitive change, why it's so important to have that testing done. One of our caregivers has asked for a little more of that. They've got a parent who refuses to accept that they need to have a comprehensive assessment done. The parents living independently, but obviously showing signs of cognitive impairment, that their personality is changing. They are not, obviously they're not remembering things, but they're not following through on actions, very quick to emotional changes and reactions.
Mhm.
So for someone, a lot of times for us as parents, it's very, as children, it's difficult with our parents to try to get them to listen to us a lot of times.
Mhm.
And so what are some suggestions
Mhm.
on how to make that conversation be a little bit more productive?
Mhm. Well, a couple of ideas. One would be, well, one approach I'll just kind of say again is just say, well, why not this is one way you can get me off your back. Let's just go to the doctor. You can prove to me there's nothing wrong with you. I hear what you're saying. You think there's nothing wrong, and I want to believe you. So let's go and check it out. And then you won't hear anything from me again. That's one way. Another way would be to have a trusted person in their life make that recommendation. So if there's a priest or a pastor or a neighbor or an accountant or someone they've known a long time who they really trust, who do they go to? Who does your parent go to for advice? And if someone else makes that recommendation, like, oh, you should really see Dr. So-and-so, sometimes that lands in a different way, kind of like if you tell your kids something a million times and then someone else tells them, it comes across different. So that's another idea. A third idea would be to just call it a general checkup. Sometimes, rightfully so, people get very defensive about when you're accusing them of having something wrong with their brain. People worry about being a burden. There's a lot of stigma with Alzheimer's and dementia. And so especially when, because of the condition is causing them to not have insight, it doesn't make sense to them. Why would I go see a neurologist, or why would I go get my memory checked when there's nothing wrong with me? And so kind of focusing on, this is just make the appointment for them and say, this is just a general checkup. We're just going to go and do a general checkup. That's less threatening sometimes than being like, well, this, and this are wrong with you, and this is why we're going to go see the doctor. You could try the Medicare benefits angle. You could say, you have this, Medicare will pay for you to go see the doctor, your annual wellness exam. And you worked so hard your whole life for this benefit. Let's make sure we take advantage of that. Let's go get that annual checkup.
That's a great one. I had not thought of that one before. I have used the third party in the past, and that has worked very well. I particularly have a friend whose father was having cognitive decline and in denial on it, and was not very safe to be driving anymore. And taking away the keys was a conversation that just went nowhere every time that it was brought up. And so this person talked to their father's GP doctor and said, we're having this issue. Will you say, as part of their next visit, you need to go and have this testing done.
Right.
And make it part of, the prescription from the doctor that this is what you need to do.
Yeah.
And so, let someone else be your bad guy sometimes helps out.
Exactly. Yeah.
Yeah. Got a question about the diagnosis of dementia. Are there imaging studies that are able to find the different types of dementias? And so if there is a concern about cognitive decline, how do we, are there diagnoses? What am I trying to ask here? What are some of the ways that we can diagnose the specific types?
Yeah. So imaging is really helpful in this respect. So there is amyloid imaging, which is currently only available in clinical trials and clinical research studies, but that is definitive. It's a biomarker. If you have amyloid plaques in your brain and you have a positive amyloid scan, that's a good indicator that there's Alzheimer's disease present. Sometimes people who are younger and have amyloid present, they don't have symptoms yet. And so, that's why it's still in clinical trials. They're still trying to better understand how that works with a diagnosis. We typically in our clinic, best practice is an MRI. And if a person has a pacemaker or claustrophobic or any other reason why they can't get an MRI, we'll take a CAT scan, because insurance will also pay for a CAT scan, and you can look at structural changes. You can see a mass on a CAT scan. You can see shrinkage and atrophy on a CAT scan, just as you can an MRI. And so on an MRI, you can see vascular, well, in a CAT scan too, you can see vascular damage. So it looks like white spots come up. You can see if the person has had a stroke or many strokes, and sometimes that can give us really helpful information on what type of dementia someone has. If you're seeing a lot of atrophy and shrinkage in the front part of the brain, that can be an indicator of frontal lobe dementia. You see a lot of symptomatically, clinically, you see behavioral disinhibition, personality changes, lack of empathy, usually presents younger, in early 60s, and that it's pretty obvious on an MRI scan if there is atrophy in that area. With Alzheimer's, we're looking for shrinkage in the hippocampus, which is in the temporal lobes. And so we can definitely see that on an MRI. It looks like there's actually two holes in the middle of your brain where there's fluid, where there should be a white brain matter. And so it's pretty clear on an MRI if there's shrinkage in the hippocampal region. You can also see other conditions like MS show up very clearly on an MRI, neural pressure hydrocephalus if there's fluid on the brain, or enlarged ventricles. So there's really a lot that we can rule out and rule in if there's a presence of something else for imaging. A PET scan, if we have an MRI and we're not sure if it's frontal temporal lobe or Alzheimer's disease, we'll order a PET scan, and that shows activity and metabolism in different parts of the brain. And so if different parts of the brain are less active, we can usually tell which parts are struggling more than others.
For those of us who are caregivers and we are concerned about our loved one who is starting to show cognitive decline, what is our steps here to get to getting these types of tests? Number one, we're going to go to our GP and say, we have this concern. The GP is then going to make the recommendation to or referral to neurology. Is that what are our steps here?
Yeah, that would typically be the next process. So primary care physician, ask them for a referral. If you want to come to the Comprehensive Memory Center, they'll just send a referral to the center, and then we'll do all of that in-house. And there are other great neurology clinics here too in Austin if you just want to see a neurologist, and then they will send a referral for neuropsychologist or psychiatrist or whatever is clinically needed. Perfect.
Got a question again for a loved one. We know that to help slow cognitive decline, our big three: eat well, stay physically active, and stay socially connected. Got a caregiver whose mother has macular degeneration and hearing loss. She is in her mid-90s. And so she's very limited on what she can do. Some very minor exercises, but it's mostly walking inside the house, watching some TV, but has a very short attention span. Are there any recommendations on other activities that might be helpful for as our loved ones get further along in age?
Mm-hmm. Yeah, that is a really good question. So I didn't hear that they had cognitive impairment, just a short attention span, macular degeneration, and hearing loss. I think sensory activities, are really important. So thinking about, if they're like a kind of activity board, sometimes with like zippers and buttons, and if she has good dexterity, sometimes that can be good just to have like that kind of stimulation. I know that there are support groups of people who are hearing impaired that have like the kind of closed captioning. So that I think, audiobooks I know is a really popular one, and using headphones for people who are hearing impaired. That can be really helpful, and listening to music, listening to documentaries, all of those things, even if you're hearing impaired, to really put the headphones on, that can really help.
And again, referring back to our Striking Balance conference that we had last month, our 20th anniversary, we had dementia experts who presented on activities that you can do with your loved one all through their cognitive decline. And so if you just go to YouTube and you just search for Age of Central Texas, you'll find our full list of all of those videos. And there are some great PDF handouts that went with them that you can just click and download, and it'll give you like a list of 100 things that you can share with your loved one and that you can do together. So there's some great things that you can access today on that. Got a question specifically about the UT Comprehensive Memory Center. On average, how long does it take to be able to see someone? Do you have a current waiting list? And does the center accept insurance?
Yes, we accept insurance. We accept all major insurance providers. And it can vary depending on which provider you're wanting to see. Our speech language therapist has a month-long waiting list. And so after a diagnosis, it'll take about a month or so to get in for our social work counselors like myself, generally a week or two, maybe to get an appointment with us for an initial like diagnostic evaluation. Sometimes people are coming in for a second opinion if they already have a diagnosis from another provider. We'll usually have them see our advanced nurse practitioner, and we just get the records from everywhere else, and then our whole team will work together to kind of consent, and if there's any missing pieces, that can typically happen pretty fast too. If you're getting an initial appointment, never having a diagnosis before, we're getting a referral from primary care physician, it can take a month or two usually to get an appointment. I know other clinics have been closed to new patients or had 6 months to a year, and so I know it can feel like a really long time to wait. Anytime is a long time to wait because we want the diagnosis yesterday, but sometimes it just kind of depends on the time of year and how busy our referrals have been.
And of course, with COVID, everything has been expanded out on time for a lot of services. So
Yeah.
We understand that it's a whole new world when it comes to care these days. For those of us who have a loved one who this would be the first time that they would be having a diagnosis made, we've suspected there might be an issue. We're going to go, we do the test, and it does come back, yes, we do have a cognitive issue. What happens at that point?
So when we give a diagnosis, we also give the patient and family a care plan. And that care plan includes research studies that they're eligible for. It includes a recommendation for counseling services if there's been any emotional health or mood issues identified. And in counseling, we do a lot of the education and connections with community resources like AGE and getting people into a support group or adult day program or memory connections and those kinds of things. Oftentimes we'll recommend a driving assessment if someone is still driving and we have concerns about driving. We'll sometimes recommend speech language therapy or home health services if there's a need for physical therapy. What else? Book recommendations, community classes. And so typically you'll get the diagnosis. If we start a medication, we'll recommend you come back in 4 to 6 weeks to see our nurse practitioner, telehealth, just to make sure that there's no side effects and that everything is going okay with the meds. And then people can continue to see our nurse practitioner or counselors ongoing.
Fantastic. We've had several people asking about if we would recommend a specific home health care company, and that is not something that we do. However, couple of things to keep in mind. One is that we've got some great home health care companies that are sponsors of this conference. So take a look at your program, another plug for the program, and contact one of those guys because they're folks that have been in our world for quite some time and we know them personally. So they would be ones that we would certainly recommend. Also, I would recommend the Age of Central Texas Caregiver Resource Center. You can contact us by phone, by email, send us a message off of our webpage, and we can help you find a resource specific to your needs. A lot of times it's hard to try to go through the whole list because there are hundreds of them here in Central Texas and know who does what. And so we can help you narrow your search based on criteria such as how much do I have to spend for this? Am I looking for nursing cares or just somebody who's going to come in and do some home assistance? What part of town does it need to be in? Do we need a specific type of caregiver for our loved ones? So we can help you narrow that search down a little bit. So give us a call, and I will at this point also make a plug that I always do at these sessions, which is remember there is never ever any shame in asking for help, because all of us need help at some point in our life as caregivers. I'm a caregiver as well. And one of the hardest things for me to do was to overcome, I work in this industry and, you would think I would know everything and what to do and where it all is, and I don't. And to ask for help and say, I don't know what to do in this situation, is sometimes it feels embarrassing to us. Don't ever feel that way, because none of us were ever taught everything we need to know about how to be a caregiver. And so that's why organizations like Age of Central Texas, like the University of Texas, like AARP, why we're all here is to provide those resources when we need them in our journey. So never ever feel like you are less than by asking for the help, because that's why we exist. One last quick question for you. We touched on some of the difficult behaviors that come with dementia, like shadowing. Sundowning is one that a lot of caregivers have to deal with here in Central Texas. Do you have any suggestions for a loved one who is sundowning? And maybe explain what that is for folks who don't know, but I know there's a lot of caregivers on here who are dealing with that very issue.
Mhm. Yeah, sundowning is usually in the late afternoon, early evening, where behaviors tend to increase or anxiety increases, and it can become they may be more irritable, or it just becomes more challenging that time of day. I think I always ask myself, okay, kind of step aside and kind of think about the situation. It's usually when it's been a long time from lunch, it's about dinner time. It's nap time for a lot of people, or they're kind of getting tired. It's that kind of siesta time of day. And so thinking about, okay, are they tired? Are they hungry? Are they bored? Oftentimes, it can occur when the caregiver is like focused on getting dinner ready and there's not a lot of stimulation. And so kind of thinking about, okay, what could be the cause of this behavior? And is that a time of day where we can go maybe do something else, or maybe we go on a walk right before this behavior typically happens to kind of like tire them out. And then we can, maybe they'll be more comfortable just watching TV if they've kind of gotten their energy out before that more difficult time of day. So it's kind of behavioral interventions in that way. So kind of asking yourself a lot of different questions about when is this happening? What might be going on physically for the person? Are they hot? Are they cold? Are they tired, hungry? That kind of thing. And then thinking about maybe it's just the time of day we need to get out of the house and go for a drive, that kind of thing. Shadowing behavior is when a person with dementia feels more comfortable and at peace because they are in eye shot of the person who represents comfort and safety and reassurance to them. And because of that, when that person is out of eye shot, they get anxious and irritable. So they start doing what we call shadowing behaviors, where they kind of follow you around the house, or they're always right there, right behind you, asking you lots of questions. And so setting them up with an activity can be really helpful, something that's engaging them, but that's what shadowing behavior is.
Thank you so much. Alyssa, I want to thank you so much for spending your morning with us. I know that you're very busy, and I so appreciate you taking this time to share your expertise and your knowledge. And it's so wonderful to know about all the tremendous work that's happening over at the University of Texas Comprehensive Memory Center, and that we have that as a resource here in Central Texas. So thank you so much for sharing all that information with us and preparing this wonderful presentation.
You're very welcome. Thank you so much for having me, and enjoy the rest of your conference.
Thank you. And thank you to you for joining us this morning. We know that as caregivers, it's often difficult to take the time out of the day to learn some new strategies and find out about new resources, but I'm so glad that you joined us today. We'll be back tomorrow. We're going to talk about driving tomorrow with the St. David's Adaptive Driving Program. So we hope you have a wonderful rest of your day, and we will see you for tomorrow's session. Bye-bye.